Welcome to our webinar. I'm Angela Jones. I'm joined today by Rhonda Garrard from the Monash Centre for Health Research and Implementation. Rhonda's the education lead, including programs in implementation science and healthcare improvement, and will be co-facilitating our webinar today. And the topic is implementing improvement in healthcare learnings from the front line. For those of you that may be first-time attender of a Monash Partners event, Monash Partners is an NHMRC accredited research translation centre, bringing together 12 healthcare research and teaching organisations. Our purpose is to connect researchers, clinicians and community to innovate for better health. And we have three speakers who will be presenting today around their real-world examples of implementing change in the context of healthcare. I'd like to begin by acknowledging the traditional custodians of the land on which we're meeting today in various parts of Australia, and in a spirit of reconciliation, I pay my respects to elders past, present and emerging, and also extend that respect to any Aboriginal and Torres Strait Islander people joining our webinar. We acknowledge and pay respects to First Peoples across Australia. So I'm delighted to be joined today by three speakers, Diana, Egerton-Warburton, Shanal, Kumar and Ester Roberts, who will be speaking and providing perspectives on different applying implementation science methods to increase the impact of healthcare improvement in various settings, in emergency contexts, in patients living with cystic fibrosis, and also in innovative models of care such as an at-home subacute service. It's my great pleasure now to stop sharing and to invite Diana Egerton-Warburton for her presentation. Diana is an emergency physician and the Director of Emergency Medicine Research at the Monash Medical Centre. She brings a wealth of experience in implementing healthcare in emergency contexts, and she's also the chair of the Monash Partners Emergency Care Sub-Theme. Thanks, Diana, and over to you. Diana, you'll just need to unmute yourself, I think.
There we go. Great. Thank you. Excellent. It's always good to start with an unmute experience. Thank you. Thank you, Angela. And I'm looking forward today to talking about really it's 10 years of healthcare improvement that we've done on one particular subject. But first, I just wanted to share with you this picture. I really like it. But it's not exactly what you think it might be. It was actually created on a Petri dish by Alexander Fleming, and he used different bacterial colonies to create the picture. And Fleming believed a lot in using design and design thinking in his observations and his research. And he commented that the lines between art and science blur in the same way as in this picture, where over time the bacterial colonies will overgrow each other and the lines will blur in the picture. So it literally lasts for less than 24 hours. And the soldier's sleeves and collar and the magnificent emblem on his helmet are actually Staph aureus, but Staph's not always marvellous. This is Charlie. Charlie was 3 days old when he presented to Monash, to an emergency department at Monash Health. His parents were concerned that his skin was yellow and that he was sleepy. He had a cannula inserted and bloods were taken, and then he was admitted for some IV fluids and some phototherapy. And this is Charlie 4 days later, after he had 2 cardiac arrests on the ward, which were due to Staph aureus bacteremia, secondary to his intravenous cannula. And Charlie had significant complications along from that and will sort of never have a normal life. This led Monash Health to look at Staph aureus, healthcare acquired Staph aureus bacteremia. And we found, to our surprise, this was a study of 5 years of healthcare acquired Staph bacteremia at both the Austin Hospital and Monash Health. And to the researchers' surprise, they found that almost a quarter of cases were due to the simple IV cannula. And previously, people had related it to central lines and hemodialysis catheters. So this was quite a surprise. And in fact, 60% of those cannulas were inserted in the ED or in the pre-hospital state. So Rhonda Stewart actually came to me and said, we're going to remove all the ED cannulas and replace them on the ward. And I felt that it was worth taking a step back and looking at the bigger picture. Just to put these cases into perspective, they stayed in hospital an extra 21 days. They cost between $30,000 and $40,000, and a quarter of the people died that had this condition. And in terms of Monash ED, that was a case every 40 days from our ED with these very poor outcomes. What this did was really create a healthcare emergency at Monash Health, and it gave us impetus to change. But when we looked at the cannulas that we're inserting in the ED, I believe that cannulas have become a bit like water to fish, so much part of the environment that we weren't really recognizing them. And we did this study which demonstrated that exactly half the cannulas we inserted in our ED were unused, and we called it pain with no gain. And of those unused cannulas, 90% were used to take blood. If you had an unused cannula and you're admitted to the ward, then once again, half of those were not used 3 days later. So it was literally like a little focus for infection hidden under your pajamas. And we wanted to address this issue, and we didn't want to sort of jump to the normal manner of putting in a guideline, but use a human factors approach to it. So people would be familiar with human factors. It involves thinking about 3 key elements: the people, and particularly their heuristics or their beliefs, the equipment that they're using, and the environment that they're in. And the idea comes originally from high-stake industries such as the nuclear industry, and it's to try and avoid error. And on this basis, we came up with this multimodal intervention, which involved going in and having clinician focus groups to really understand what their beliefs were. We actually called the program to begin with Think Before You Prick, but we were told after we had the CEO as our champion that we weren't allowed to use that expression. So we kept getting this recurrent theme from clinicians that they were doing it to be safe and just in case. So we came up with Just Say No to the Just in Case cannula. And we used elements including audit and feedback, and equipment changes were key. We renamed our cannula trolleys vena puncture trolleys. We had about 6 different ways of taking a vena puncture, none of which the clinicians liked. So we got new equipment. We put that on the top drawers of our trolleys and put the cannula equipment further down. One of our key elements was when to insert a cannula, and from our focus groups, we discovered that clinicians had very little time. Initially, we started with a giant inclusion process, but we did a modified Delphi approach, asked clinicians, and they told us that they had very little time, so we needed to have a simple rule. And that was, are you 80% sure that your stable patient is going to need intravenous fluids or intravenous treatment, in which case put a cannula in. We've published 3 papers about or at least 3 about the effectiveness of this intervention, and we demonstrated between a 10 and 20% absolute reduction of cannula insertion, and we sustained that change for 5 years. It was also translated to Queensland, where they produced similar results. Our use rate went up to 80%, and we had we measured sort of for adverse or unintended consequences, and we didn't find any of those. And this project was implemented as part of a statewide process in Victoria and Queensland. And I suppose everyone is wondering, well, what about cases like Charlie? And very pleasingly, having taken that graph back 5 years, a case every 40 days, we had almost 2 years without any cases. So from my perspective, I was a bit like, well, mission complete, but something was coming around the corner for us. And that was that the health service chose to introduce this process of accreditation. I'm not going to go into too much detail today, but it was incredibly complicated. It involved this large pack was supposed to be a one-size-fits-all for people inserting cannulas. It involved a 58-page background document, a 48-page procedure, and 7-minute video, multi-choice proctored exams, and literally thousands of clinicians were put through this process. I guess you're all wondering what could possibly go wrong. The PACs bamboozled clinicians. They were confused about the equipment. That often mixed sterile and non-sterile field. Immediately, they created a huge carbon impact and cost with the packaging and the process. We can see the outcome. The red here are the cases of Sabacteremias, and you can see with the Just Say No, we had a reduction of cases, and then with the guideline process, we saw this concerning increase in cases. The blue line is the number of cannulas inserted, so that demonstrates we'd kept it the same. And not surprisingly, time series analysis demonstrated statistical associations. But as a clinician researcher, I always think about the patients, and this was Pat. Pat was a retired nurse, and she, became one of the champions of our projects and told her story. And it was Pat who really pointed out to us that this dressing that the clinician didn't seem to know how to put it on. And we'd done spot surveys and found that half the cannulas inserted and sent to the ward didn't have their key parts covered by an occlusive dressing. And this was the classic one where you can see the whole insertion site. And I felt like the dressing was acting like a sort of runway, landing a plane onto it. Now, at the time, we asked the organisation to change the pack, but we were told it had nothing to do with the equipment. We just needed to focus on aseptic technique and no-touch technique. Every one of the clinicians involved were de-credentialed and taken back and had to go through the credentialing process again. And it was very much a basis of, they just need to use this equipment correctly. Now, having done all the work, I felt like I was literally on a sinking ship. But as we know, things that work well and good for the environment involve design thinking. Now, I don't have time to go through the whole design process or design thinking, but design thinking is similar to human factors, but has a little bit more honey to it, and it's more about developing deep empathy. This is one model that you can use, which is the double diamond model. But one of the key elements of the research is ethnographic research, where you embed designers in the ED. And that's what we did with our cannulas and our packs. We did a really complex journey mapping to make sure that there was not going to be any unintended consequences, particularly with carbon issues. And we had a very exciting design phase, which involved researchers, clinicians. You can see patients. There's Pat there. And really, in our design phase, there was really no ideas were too bold. And we came up with a number of things which are with the company for to see whether they're commercially viable. But it was very useful for Monash Health, and it was helpful to have that voice coming in to tell us that our current design was wrong. We ended up with a very simple pack at Monash Health for the frequent user, a rectangular dressing, and no equipment to bamboozle the clinicians. We immediately, within the first 6 months, saved $500,000 of equipment costs and reduced carbon footprint. This is just a quick look at a study we did on the cost of ED cannulation in Australia. And we estimate that it's about $500 million a year, of which a quarter of that represents cannulas that were never going to be used. And the unused cannulas represent about 13,000 clinician shifts per year, which is useful for engaging clinicians in change when they don't like to think of themselves as having to be economic rationalists. So where did we end up, and what about the cases like Charlie? Well, we can see here when we introduced our simple packs, we've had a slight increase in cannulas, which may have been related to our new EMR and possibly due to COVID with the increased acuity, but we had a fairly dramatic reduction in our SAB bacteremias. And our research was cited in the Commission for Safety and Quality's Clinical Care Guideline released in 2021, where they talked about the just-in-case cannula. And the first indicator is a cannula not being used for therapeutic purposes. On the back of this, we applied to the MRFF for a grant to look at a step wedge trial of our intervention in diverse EDs, and we were successful to get almost $3 million to look at this over these 3 steps, which include a step wedge trial, using implementation frameworks to both do adaptive co-design of our intervention, and then implementation effectiveness with the RE-AIM framework. We then aim to do a full cost effectiveness analysis, and then a model for a national rollout and implementation toolkits. And our project will be largely based upon the learning health system. So in the grant application, I did comment that it doesn't exactly seem like rocket science to make a caring clinician not put a cannula in that they weren't going to use, but it does take implementation science to do it on a national way, in an effective and scalable way. So thank you.
Diana, thank you for your presentation. I just encourage everybody to pop questions into the Q&A, comments into the chat. We will have time after our presentations for questions, so please keep those coming through. It's now my great pleasure to introduce our next speaker, Dr. Shanal Kumar. Shanal is an endocrinologist at the Princess Alexandra and Prince Charles Hospitals in Queensland and a PhD student through Monash University. She's using implementation science frameworks and qualitative research to co-design models of care for patients with cystic fibrosis. And today she'll be speaking to us about her experience of that work. Thanks so much, Shanal. Welcome, and over to you.
Thanks, Angela, for that warm introduction and the opportunity to present my research. I'm just going to share my screen. So I'll be talking about my purpose today, which is to help adults with cystic fibrosis live healthier and longer lives. And I've been doing research in this field, and part of my PhD, I am co-designing a model of care for adults with CF, as well as co-designing a pilot implementation trial. So that's what I'll be talking about So you're probably wondering how I got into such a niche field, and I've always had interest in diabetes. And as an endocrine registrar at Monash Health, I came across adults with cystic fibrosis and realized that their diabetes was really challenging to manage. They had complex factors affecting their blood glucose level. The evidence base to support their management was poor, and expertise was limited in this space. But what I did find was that they had a really well-established consumer advocacy and community-driven initiatives, and this was really appealing to me. And I was working part-time after return from maternity leave, and an opportunity arose to engage in research in adults with cystic fibrosis. And it was a prospective trial looking at continuous glucose monitoring, which is devices that people with diabetes can wear to get real-time blood sugar levels. And we found in this pilot study that the blood glucose levels on CGM actually predicted recovery of lung function in adults with cystic fibrosis. And this was really exciting. And the first author on this paper, Michael Palin, and the senior author, Georgia Soldatos, then ended up being my PhD supervisors, because that was something that I was really interested in evaluating further. And so this research really showed that blood sugar levels rise during acute infections in adults with CF, and that maybe optimizing their blood sugar levels during this time might positively impact their lung function. And continuous glucose monitoring could help in this decision-making process and improve blood sugar control. But in the first instance, there was minimal evidence base to guide CGM use in CF. And so my PhD timeline looked like this. I started it in March 2020, and it involved evidence synthesis with a literature review. And then the plan was to design and conduct a prospective interventional trial to further evaluate CGM in adults with CF. And during this time, I hope to, I was planning to engage in qualitative research methods and learn more about them, and implementation science as well. But of course, COVID happened in March 2020, and that really changed the scene, because for adults with CF, which is predominantly a respiratory condition, the workforce there was shifted and changed priorities. And then I ended up falling pregnant and having my second baby during my PhD as well. And so this really changed my perspectives as well as the field. So this changed significantly in the 2 years between 2021 and now, where CGM became subsidized for all people with type 1 diabetes, but not adults with CF-related diabetes. Highly effective modulator therapies became subsidized in the PBS for use in adults with CF, and this really changed the landscape for their lung disease. And there was new diabetes medications that became available as well, specifically for people with type 2 diabetes, and their use in people with CF may be beneficial, but there was not really any evidence around it. And so I had to think deeply about how to keep the research that I was doing relevant, translatable, and transferable in this space. And luckily, I was doing implementation research. So one of the projects that I was doing was to co-design a model of care for adults with CF-related diabetes, and now for the post-modulator era. And so part of this research was looking at how we deliver care within a healthcare system, so the model of care. And the end users were adults with CF, as well as the healthcare providers caring for them. And I used implementation frameworks to design questionnaires and focus groups and semi-structured interviews to look at not just the clinical outcomes, which clinicians are usually interested in, but also the barriers and enablers to an ideal model of care, and the experience, engagement, and satisfaction with the model of care. And I used the consolidated framework for implementation research, so the CIFRA framework, to identify the contextual factors that were impacting the end users. So for consumers, things like the inner contextual factors, so things like barriers to self-management. I could see someone with diabetes every couple of months, but they were living with diabetes and managing it on a daily basis. So it was really important to identify what were the barriers and enablers to that. With modulator therapies, a lot of adults that I was seeing clinically said that they had increased appetite, and with this led to quite rapid weight gain, requiring dietary adaptations. So there was that changing clinical management as well. And with longevity that the modulator therapies offered, people with CF who were living mostly in the here and now had a change in mindset about longevity. And this was something that was changing the way that they now viewed metabolic health and their diabetes. There was also outer contextual factors like diabetes stigma, availability of appropriate educational resources. So, for example, Diabetes Australia has a lot of guidelines and evidence to support management of people with type 1 and type 2 diabetes and gestational diabetes, but nothing specifically for people with CF-related diabetes, and policy affecting access and subsidization to CGM. Healthcare service contextual factors were also important, such as leadership, organizational culture, and resources for expansion, as well as funding and consumer advocacy. And healthcare providers, so what was their capacity and expertise to manage this condition, their and the lack of guidelines and consensus to help guide their clinical management. So these were all important factors that I identified using the framework. And I needed a structured approach because there was a lot of things clearly impacting here. So I decided to break it down into individual, service, and system level issues. And so individual barriers I identified as being finger stick blood glucose sugar testing and lack of access to subsidized CGM, dietary recommendations, and acute lung infection. And this was through a consumer survey. Service level barriers were identified as desire for consistent advice, easy access to an endocrinologist, and integration with research. And system level barriers was access to subsidized CGM, increased visibility of CF-related diabetes as a distinct entity from type 1 and type 2 diabetes, and nurturing expertise and research in this area. And so then I started. So one of the biggest ones was lack of access to subsidized CGM, and that linked in with that system level barrier of policy. And so part of the work I've done is drafted and submitted a collaborative submission to the National Diabetes and Services Scheme, asking for CGM access to people with CF-related diabetes to be subsidized, same as it is for adults with type 1 diabetes, and also to the parliamentary inquiry into diabetes, which is currently underway. And this was supported by a systematic review that I published that showed that in a meta-analysis comparing continuous glucose monitoring to finger stick testing, that there was improvements in HbA1c with CGM. With the dietary recommendations, I'm currently collaboratively working with dietitians in this space to come up with some consensus guidelines, particularly with how to manage weight gain in people with on modulator therapy. And acute lung infections remain an issue that is a barrier to glycemic control in this group. And so I'll speak a little bit more about co-designing a pilot implementation trial. Service level barriers, so that desire for consistent advice really linked in with the fact that there was no consensus recommendations. And I'm currently at the Australian Diabetes Congress, where I've convened a meeting with all of the adult cystic fibrosis endocrinologists from Australia to talk about how we tackle this issue and come up with some consensus guidelines to support clinical management. The easy access to an endocrinologist really fed into that model of care. And what we heard from people living with CF-related diabetes was they wanted multidisciplinary team-based care. So they didn't want to go to a different diabetes service. They wanted to see an endocrinologist who was integrated within the CF service. And then the integration with research was really important as well. And CF is fantastic in that they have a national registry. So each CF centre has a database, which then feeds into that national registry. So there was a real opportunity to do database-driven research here and visibility of CF-related diabetes as a distinct entity. System level barriers actually led to networking and collaboration. And we found that women with CF are having desiring fertility and increasing rates of pregnancy. So there was that collaboration that was needed with the high-risk obstetrics team that are looking after them, and as well as improving transitional care from the pediatric setting, and as well as the adult endocrinologists who are working within the dedicated CF centres. nurturing an expertise and research in this area, I've engaged all the relevant stakeholders, so community-led organisations such as Cystic Fibrosis Australia, the hospital executive at the site where I'm working as a CF endocrinologist to see what the barriers are to the current model of care and how we can co-design it better. Health professional organisations like the Australian Diabetes Society, where I've used it to increase visibility of CF-related diabetes and the different needs of this population, as well as industry. So I've had conversations with the industry makers and funders of CGM themselves. And of course, those collaborative submissions and increasing consumer awareness, advocacy and involvement to help this inequitable and unfair lack of access to CGM for this population. So in real life, as a clinician, what I've done is since I've started as a CF endocrinologist at my service, I've identified all the adults attending the service using a database, completed an audit, stratified them according to their diabetes status and started seeing them. So prioritized appointments. And throughout this process, I've just increased visibility of diabetes within the multidisciplinary team and also embedded implementation frameworks to evaluate how we make the change. So I wanted to move on to the next project that I'm doing, which is co-designing a pilot implementation trial to evaluate CGM in adults with CF and diabetes. So this is an important barrier at an individual level for people living with CF. And the goal of, I guess the hypothesis for this is optimizing glucose control improves disease-specific clinical outcomes. The participants, again, are people with CF and healthcare provider end users. The pilot is using CGM in a process of care to monitor and treat the high blood sugar levels. The context is the hospital admission for an acute lung infection, and I'll be using the RE-AIM implementation outcomes as well as looking at acceptability as an outcome for this trial. So the real life is that COVID really reduced hospital capacity for elective CF admissions. And now that the pandemic has passed, modulators has reduced pulmonary symptoms in adults with CF. So we're not seeing that many adults with CF on modulators actually having acute infections. And funding and CGM access to type 1 diabetes has really led to reduced interest in industry-supported or industry-funded trial in this space. But I'm trying to see the silver lining in all of this. So with COVID, there's been improved virtual healthcare infrastructure, and that really lends itself well to diabetes technology and integration of that within a model of care. With the modulators, this has actually selected out the population that are most likely to benefit from improvement in their glycemic control. So non-responders or those who are unable to tolerate modulator therapy are perhaps now at the greatest risk of pulmonary decline from their high blood sugar levels. And the lack of funding for CGM to adults with CF-related diabetes has really driven this initiative for fair and equitable access. So what I've learned is that implementation research should really be with the consumer at every level engaged. And to do this, we need to communicate well with consumers and focus their attention on a priority issue that is shared. Implementation research has allowed me to make sure that my research is relevant and translatable and transferable. And throughout this process, I've really enjoyed having the support of the implementation course, which I know we'll be talking about later in this webinar, because this was not something that I learned as a clinician so far throughout my journey. Thank you.
Shanal, thank you so much. Impressive body of work.
Thanks.
Over to our next speaker, Ester Roberts. Ester is an allied health lead at Peninsula Health Service down on the peninsula, and she's led a project which was very challenging in the context of COVID around an innovative approach to care, and it was called the At-Home Subacute Service. So Ester is going to provide us with some insights from her experience of implementing this new model of care. Ester, over to you. Thank you.
Afternoon, everyone. I'm just going to share my screen, so hopefully this all works for you. I'm usually a Teams user, not a Zoom user, so we'll see how we go. Okay, All right, so I'll be talking about implementing our at-home subacute service down at Peninsula Health. So our at-home subacute service at Peninsula Health is a combined bed substitution and community ambulatory.
Esther, we might just try and take you to presenter view if possible.
Sorry.
No problem. Just
how do I do that?
So you might need to end the slideshow. I might get Victoria to just come on and provide you with some guidance as well, just for a moment.
Hi, Esther, just in the display settings, you should be able to see.
I don't know how to do that. Talk me through it.
That's okay. Did you want me to share the slides from my?
Yeah, you share the slides from your end.
Just give me 1 moment, everyone. I'll just pop them right up. 1 second.
This is where the differences between Teams and Zoom come into play.
Absolutely. Just
1
the
moment.
little nuances. Thanks, Victoria.
All right. So yeah, as I said, I'll be sharing some insights in terms of implementing our at-home subacute service at Peninsula Health. So next slide. So the at-home subacute service at Peninsula Health is a combined bed substitution and bed diversion program, which provides early supported discharge model of care. We use a combination of inpatient and community ambulatory funded funding models, and the service is designed to provide flexible levels of care depending on the needs of the patient along their subacute and ambulatory journey. At-home subacute provides an intensive subacute care in the community with a length of stay of 2 to 6 weeks. And we can provide medical, nursing, pharmacy and allied health, as well as supporting patients with brokered care services as needed. Most of the care is provided to patients in their own homes and communities, with the exception of group sessions and patients who have home visit risks where care is provided in a centre-based environment. Next slide, thanks. So you can see here the structure of our service. We've got a 23 beds under admitted funding or bed substitution funding, and these are allocated to a rehab, GEM and PAL care pathways. Our community ambulatory stream is split between neuro, ortho and reconditioning and caters for about roughly 40 patients. And our allied health team also provides services to the acute hospital in the home service, including our gen med and cancer care streams. Next slide, please. So the implementation journey has been a long one for the at-home subacute service. From 2017 onwards, health services started investigating options to shift inpatient care outside the hospital walls. And each health service has used their funding differently, focusing on different points in the continuum of care. But over the last 2 to 3 years, subacute and community ambulatory services has been a major focus for Better at Home funding, particularly with GEM and rehab at home services. In 2020, Peninsula Health started developing their Better at Home projects and models of care, and a needs analysis and stakeholder engagement were completed at this time. A subacute model of care was developed by a project team, and change impact statements were rolled out and signed off over the course of 2021. In late 2021, a Peninsula Health project team employed the leadership team to assist with the rollout of the new at-home subacute service. So further stakeholder engagement happened at this point, especially with staff in existing early supported discharge services who would now be coming under a new service banner. And change management strategies were employed at this point to assist staff with transitioning through that change. Operational and leadership structures were discussed and leadership positions recruited to, and recruitment of new staff commenced. Moving on to the service implementation, the senior leadership positions were prioritised for recruitment, with senior allied health NUMs and ANUMs in intake nurses, and then further recruitment across 11 different professions to build the team. And we're currently over about 70 staff. Senior allied health teams helped build the professional workflows, and discipline-specific services development commenced. Interprofessional integration is happening along the way, and our physical resources and office space are required later in 2021. Next slide, please. So for all of this implementation, the knowledge to action framework was utilised. Within the implementation of our service, both big picture views as well as more micro views were required for different aspects of service development. And the knowledge to action framework assisted with both broader and micro implementation and allowed visibility of planning and planning for professional and discipline specific aspects of service development. So I'll go into the use of the implementation in the following slides, but I thought it was relevant to show what we've implemented over the last 18 months. Next slide, thanks. So this is some of the things we've implemented. We've developed a model of care and refined that model of care as we've gone. Recruitment and team development across 11 or 12 professional groups. We've implemented our intake and admission processes, our medical escalation policies. We're implementing outcome measures across professional groups. Our referral and processes and to non-blanket professions have been implemented. Discipline-specific priority tools are implemented, discharge processes and length of stay expectations, staff and patient scheduling systems, rapid rounds and handover processes, patient case conferences across 3 different streams of care, caseload management across 9 allied health professionals, team space, physical resources, equipment cars. So you get the picture. There's been a lot of very dense recruitment implementation over this time. Okay, next slide. So what we've yet to implement, and we still have a few, believe it or not, a few things to implement and a few things coming. And some of these things include allied health assistant competencies and training and interdisciplinary staff competencies, looking at key contact person for a patient's communication. We're still in the middle of our discipline-specific outcome measure implementation, and just also getting our group and aquatic therapy options up off the ground. We're looking at evaluation and research on the success and effectiveness of the service. And we're also currently implementing a few different pathways, clinical pathways within the team as well, including a community PAL care pathway and an orthopaedic pathway. So if we go to the next slide. So you've seen what we've implemented and what we're focusing on now for our next stages of implementation. So we'll head back to the framework. The knowledge to action framework was utilised to inform the implementation process. If I can just click on to get the first piece of information popping up. Lovely, thank you. So starting with problem identification. So within this implementation process, there was constant identification of gaps and problem areas or areas for improvement, such as the referral and intake process for the different streams of care, or the patient and staff scheduling. Next one. Adapting knowledge to the local context was super important for us, as we had a hybrid program straddling both inpatient and community models of care and funding systems. And a lot of the traditional inpatient processes were no longer relevant as we were treating patients in the community, and a lot of the community processes were not applicable to our inpatient system. So a lot of development of service and service-specific systems went on in this space. Next one. Barriers and facilitators. So being able to assess the barriers and facilitators for the implementation was key to the bigger picture, and having this as a key part of the model was a reminder to consider forward thinking in relation to specific or known barriers, and to be more effective in the rollout phase. The select, tailor and implement section was key for our implementation. So as I said previously, many of our existing processes were not quite the right fit and came either wholly from the inpatient setting or wholly from the community setting. And we needed to select what we thought was going to fit best, tailor that to our new context, and implement that locally. And this section of the model also helped us to frame the implementation for the development of workflows for profession-specific workflows, and allowed the team to delegate responsibility for different facets of the overall implementation. So the next three parts of the model we're currently right in the middle of and provide structure for us to be able to implement evaluation of all the things that we've been implementing and doing over the last 18 months or 2 years. So this section of the implementation model reminds us to lift our heads and take a step back and look at how we evaluate our outcomes and make that knowledge sustainable within our systems. So, you know, things like how have our changes been effective and being taken up? How is the new service being utilised, by who, when and how? And evaluation of service outcomes and how we look at that on a regular basis. Okay, next slide, thanks. Okay. So in every implementation journey and in every implementation model, it seems, there are always challenges and our implementation has not always been a smooth one. But for every challenge, there were certainly some wins as well. So some of the challenges that we experienced in our team was a rapid implementation with a really swift start date. We had very much a just start mentality, which was sometimes challenging with working with the implementation models, wanting to take that step back and do the planning when we just needed to get going. Integrating established teams into a new format and the angst that came with this from existing staff. Recruitment in a tight workforce environment. I'm sure everyone's experiencing this, but also getting the right skill mix for the service model that we were implementing. We had some conflict between professional groups, especially in the early stages. And I think that was probably exacerbated by different professional workflows and different professional working styles. And one of the ongoing challenges for our team also has been change fatigue. So we've got a rapid implementation, a rapid change, and a lot of it over an extended period of time. So we're constantly changing and upgrading and implementing new things within our service. But alongside these challenges, we've also had many wins as well. The flexibility and ability of the team to roll with the punches was really amazing. And the ability of the team to collaborate on aspects of the implementation reinforced that culture of communication interprofessional working. And has cemented that within our team as well. And being able to work together to overcome the challenges has made us a stronger team and has given us the confidence to be bold to address the challenges as they arise. Okay, next one, please. Using the framework and how this has helped us address the challenges or the implementation. So personally using an implementation framework has really helped me take a step back and provide perspective in that fast-paced implementation environment. And knowing that, for me, knowing that challenges are inherent to the implementation was really important, and it was built into the models for a reason. So don't get disheartened. If you're kind of stuck at a particular point in time, you're able to move through that and make progress. Knowing when a challenge was in part due to a missing step was really helpful. So you could go back to the implementation framework and kind of identify what you haven't done, or maybe some of the steps that you've missed. And using frameworks to help others understand the implementation process as well. So this is theory, this is best practice, this is not just my opinion. There's method to my madness, and there's a reason why I'm working in this way, and also help planning for the larger aspects of service development. Next slide, thanks. So I've just put here a few strategies and learnings just in terms of the implementation process. I think one of my major learnings was don't wait to address conflict situations, be bold. There's nothing gained from ignoring it or brushing it under the rug. You need to address it and have it out in the open and be able to discuss and move forwards. No matter how good or logical your idea for change, you can't implement it without buy-in. So, getting people on board with your ideas and the way in which you're working is really important. Benchmarking, super important for our team, particularly when we were developing our discipline-specific workflows. Can't understate communication enough. Communication, really important across all facets of the service, but across all facets of staffing as well. And linking in with other health networks is really key for us. We've created a community of practice in our subacute Better at Home community, which has been really useful. Next slide. And one of the major wins for us has been some of the feedback that we're receiving from our patients who receive our care. And the feedback has been overwhelmingly positive from the vast majority of our patients. And they mainly are saying to us that we really prefer to receive our care at home. My favourite quote from the feedback has been, and one that I really think epitomises the benefits of home-based care, is this one: is so much better than lying in a hospital ward. Home is home. I'm independent at home, and I am a pretty independent chap. Okay, and that's it.
Esther, thank you. There's some great learnings and wisdom that you shared with us. At this point, I'm going to hand over to Rhonda to facilitate some discussion, and I'd ask Shanal and Diana to turn their cameras on. And Rhonda leads the Healthcare Improvement Program offered through the Monash Centre for Health Research and Implementation, and is just going to kick off. Victoria, if you could share that slide with a little bit of an overview of the program. Rhonda, over to you.
Thank you. Thanks so much, Angela, and thanks for the opportunity to be here today. It was great to hear Shanal and Esther present. They were such great participants in our mentoring program last year, and it's great to see how far they've come in their implementation learnings and the fantastic outcomes that they've achieved. So just to touch on this implementation program, and before I do, excuse me, I just want to touch a little bit on, sorry, I'm just reading a message from Helena. Can you just touch a little bit on why I've come to the field of implementation? And I've got to say my journey has really been around probably some trauma that I've experienced in my years in senior management in healthcare, where I was charged with the responsibility of introducing change, whether it was models of care, whether it was, aspects of improving care. And there was always this assumption that people had the skills and the expertise to do that. And in fact, that's not correct. And this was in the days before implementation frameworks were a thing. And it was just assumed that, particularly if you're a clinician or if you've had some kind of training, that making change is really easy and, just go ahead and do it. And what happens when you have that mindset is you go ahead and you have a go and you find that it doesn't work. And we know that most of the change initiatives either don't even get up or are certainly not sustained. And when individuals are charged with doing that and it's not successful and change is not sustained, individuals can become quite traumatized in believing that it is about them and their lack of capability, and that can be quite long-lasting. And so one of my reasons for coming into the implementation space is to show that it actually is not the fault of individuals. It's actually a science, and it's a, really quite broad science. And that if we are exposed and have opportunities to learn some of this science, as Esther and Shanal have shown, that can change everything. Because when you know better, you can do better. So just wanted to explain that's kind of why I was attracted to the field of implementation science. And so here at MICRI, we have a large education and training program. I teach into the master's program at Monash Uni in implementation and healthcare improvement. And we also found that what people needed was to learn the theory through an education program, but they also wanted a longer term support program, and what really I would describe as a community of practice, and that is the 12-month implementation mentoring program. And you can see there, it is around knowledge and skill development. It is, personalised coaching around the particular project or work that individuals are doing. And it is around learning about some of the core frameworks and core concepts. But it is also a support program. And one of the things you really need, and I'm really keen to throw this question actually over to Esther and to Shanal, is just talking about how they experienced that support in their 12-month program and what sort of value or other they found that brought to the work they were doing. So I'd like to really just throw that question maybe to you first, Shanal, and then to Esther, just to talk about how you felt or whether that was something that supported you in your implementation journey, having that kind of community of practice.
I completely agree with everything you've said, Rhonda, that as a clinician, I did not have that skill set when I started the course. And the course provided the structure that I needed to do the implementation research that I needed. And so that was that learning how to use those frameworks, what those frameworks were built on. So that behavioral research that was underpinning those frameworks, and then using those frameworks and realizing that it changes. So there's no one size fits all. And so we all had very different projects, and, we talked a lot, and it was lovely to have that community and working through it together to say, oh, well, I'm doing this, and, we're using the same framework, but we're doing things differently. And so it was really nice to be able to have that community to discuss that, because it's not intuitive at all. So it's been a great learning experience, and we're still in touch because we're still doing implementation research, and we're still using these frameworks, and we're still encountering those barriers and challenges. So the course didn't only give us the knowledge that we needed, but it's given us a community that's really helped us support and ongoing support really for this implementation endeavour. So it's been fantastic. I couldn't speak more highly of it.
Fantastic. And Esther, just any thoughts you have around that?
Yeah, I'll add to that and say for me, it was really important to have, not just the learning about the implementation frameworks and how you might use that within your particular project, but that connection with other people who are going through the same journey at the same time, being able to kind of have that support over, at regular time points across your implementation and across the 12-month program was really useful, kind of checking in. Where am I at? Being able to have ideas from others around, how to overcome your barriers, or, what aspect of the models to use next, or which models might be appropriate for where you're at. So that ongoing support for me was really important.
Yeah, fantastic. And, so all change is people change. We're all clear on that. And people are challenging at times. And I remember, Esther, a few times you coming back and saying, I just need to really debrief here in a safe space and really recharge and go back. So, thank you for your thoughts. Diana, I know, I'm so fascinated in your project, and I'm just interested in your thoughts around, the learnings, because, you saw something that was really frustrating and you tried very much to change that, and then you got guidelined. Just really interested to know, in terms of learnings and support around implementation, how did that go for you? Did you, you kind of taught yourself, you kind of, just sort out the frameworks and things that you needed? What was that journey like for you?
Look, it really was, complemented by my Masters of Public Health that I was undergoing. And so I was exposed to the frameworks through a different method, and I think the fact that I'm pretty used to having a voice within an organisation that can be heard. But then sometimes there was an example of such organisational buy-in for something that it was almost impossible. And usually on that picture with the Titanic, I describe trying to do change management at Monash Health is like being on the Titanic in the dark, doing micro Lego as it's, sinking. And so I suppose one of the things that I chose to do is bring another voice in, an external voice to amplify my message when I felt like I wasn't being heard. And that was highly effective. And one of the voices that we brought into this equation was actually the company that was supplying the packs. It was not to their advantage because, they lost a huge contract through this process. But they were, appalled when they thought that their equipment was contributing to this issue. And so that was a really powerful voice of change to introduce. Yes.
Yeah, so, that you're really highlighting there, what Helen Bevan often talks about garnering those coalitions of change, that a large part of the change, and you did this so well in your project, is around, gathering support for change and getting those coalitions of change and being able to influence and sustain those coalitions of change, which you have done so well ultimately, and now you're going into different phase of your project. I just see Helena's online, and Helena, can I throw a question to you? Because one of the things at MICRI, and one of the things that we really emphasise so strongly, and it's come through in Shanal and all three projects actually, is around that stakeholder engagement and gathering those coalitions for change. And just wondering, how you would talk to that.
Yeah. So as many people know, we've set up this Monash Centre for Health Research and Implementation for about 15 years now. And one of the main things that it's built on is stakeholder engagement. Great stories, by the way, guys, and really fantastic for people to hear your personal narratives, because we all know it's 5 steps sideways, 2 backwards and 6 forward. And you've described that beautifully. I think that the reality is that stakeholders are the fundamental foundation of this, as opposed to when you might be doing discovery research or even management change in your health service. They're really just about systems functions, and they can be done pretty quickly with not much engagement. But if you really want something to work at this very applied end, which is wicked and difficult and challenging and complex, you actually need all the people at the table. And the most fundamental thing about stakeholder engagement is you do not ever know what the problem is you're trying to solve until you get everybody to sit down together. Because my understandoscope as a clinician is very different to the understanding of the procurement people that Dana had to deal with for her cannula set, or the community people that Esther had to deal with her model of care, or even the CF people that Shanal was dealing with in her program. And the most important being the fact that the consumers don't see it the same way we do. And ultimately, the Australian communities are the funders and beneficiaries of research. And the problem they see is different to the problem we see. Esther's problem was about rolling out a model of care which had all sorts of health service imperatives, but ultimately it was the chap at home who said, I just want to stay in my bed and I want to be at home. And ultimately that was probably where we needed to start. But getting everybody together to understand the problem then guides you in what the solution will be. And so often as clinicians, and almost always as researchers, we make the assumption that we know the problem we're trying to fix, and therefore we're pushing our solution into practice. If we really understand the problem, and there's structures and processes to do that, it doesn't take that long, especially if we understand the lived experience. And Diana has this beautiful diagram, and I might have missed it, Diana, but there's this beautiful diagram which I use as an example all the time, where the whole crisis in the emergency department is people in, black box, emergency department, people out. And we just need to pull levers on the people in and people out. Whereas actually her second diagram is the complex thing she needs to change, which is the person at home with the emergency going, what do I do? And there's about 95 different pathways that they can take for their emergency care. That's where we need to start, with the person with their emergency problem and how that system all fits together, because it's not a system at the moment, which is why everyone ends up in ED. So actually we can't see what we don't know unless we get stakeholders together. So for me, Rhonda, getting them all together and getting the people Esther talked about, the stakeholders, the executive sponsors, everybody, holds everyone to account. The CEO or whoever is at your table is going to find it much harder to follow what Esther's trying to drive into practice if she or he has heard the story from 83-year-old John who just wants to stay home. And it adds a level of accountability and buy-in and shared vision and purpose, and it makes sure you're fixing a real problem. So I just can't emphasise more strongly how that is the beginning, the middle and the end of what we're doing. Is that passionate enough for you, Rhonda?
Yeah. And without any preparation to say I was going to throw you any questions, pretty good. You raise an interesting point, and I'm interested in going back to all three presenters around the issue of context. Because I find in my teaching, this is what we are not told when we're taught project management. We're not told to, raise our eye, if you like, and understand the context into which we are, putting our change, and how important it is to understand that. And I'm just kind of interested and if we just go from sort of Esther, as I see it, Esther, Diana, and Shanal, now looking back. How do you understand the importance of context, and has that your understanding of the importance of understanding the context changed in your learning transition in implementation? So Esther, if I can go to you first.
Context is key, really, and if you don't understand the broader aspect of the context, it's really sometimes really challenging to then roll out your implementation, and there's factors around the broader context that will affect your implementation. So for us, some of our broader context had to do with COVID and shifting patients out of the hospital walls to receive their care, and that needed to happen quite quickly. So within our implementation, rather than being able to take a step back and do take some time in the initial planning phase, it was very much like, here we go, you've got 2 weeks and then you'll be getting patients within your service. And that needed to happen. It needed to happen right now because of the flow issues with COVID through the hospital system. So that context had a massive impact on not only how we rolled out our service, but how we were able to kind of frame the implementation timelines and the different aspects of implementation within that.
Fantastic. And Diana, sorry.
Yeah, look, I couldn't agree more. And I think that what Esther highlighted is also one of the contexts that we had for our cannulas, which was an organisational emergency at the time, and that was a health service emergency. And that sort of context is actually key to being able to create those changes, to have that environment, compared to when you have something, and that's what the Titanic was that we were trying to stop once this whole process had been in place, a poorly implemented process that lacked co-design. Trying to undo these things is much harder than, starting with a greenfield and going, here's a context, here's your organisational emergency that needs to be solved. So it was tricky.
Yeah, fantastic. And Shanal, your thoughts on context?
Yeah, context is core for the group that I'm working with. So a key message from people living with CF related diabetes is that it's not type 1 and it's not type 2. We've got different needs. And that diagram I showed with the inner and outer contextual factors, some of them were shared with type 1 and type 2 diabetes, but there was a lot of stuff that wasn't. And so this research really needed to be done to identify those contextual factors that were distinct in this group. So context was core and key, like everyone else has said.
Helena, did you want to say anything about context?
Yeah, just to say that if you get your stakeholder engagement right from the start, context becomes critical. If you think about the real way, the frameworks are really important, but the overlay of this also is the learning health system. And it looks like it's complex with all these myriads of frameworks, but they just become tools and guides and structures. And once you start using them, you use the right parts for the right times. And a lot of them are about principles. And this sort of shared experience is absolutely critical. But I think the one of the things about context is it's just part of that cycle. And so with the learning health system, we bring evidence from stakeholders, primarily about the problem and the priorities and what we're all aiming for. So we're all rowing our boat in the same direction. The second part of a learning health system is about what the evidence shows. And it's really important that our quality improvement and our strategy people understand that, because the worlds of academia and evidence are over here. And quality improvement tends to be a little part of our organisation often, and it's run often around hospital accreditation metrics, and it's not necessarily about change management and innovation. And so when we put all of our quality people together across Monash Partners at one stage, it became very clear that the large majority of them don't use evidence and guidelines necessarily to guide practice. So it's that evidence from the stakeholders, evidence from practice, but evidence from practice is not in your setting. Like Shanal's had to create evidence for her population, in fact. But the reality is you take the best of what you've got and then you have to contextualise it. And that's part of the next quadrant of the health system, which is about evidence from practice, which is not just data. There's beautiful examples of how you can collect all the data in the world and you can benchmark it and you can feed it back to really clever people and they don't change a thing. You need more than data. You need a vision, everyone engaged, a shared understanding, best practice evidence. And the evidence from practice is not just data, it's context. What is your size of your organisation, your setting? I mean, Esther's stuff spanning all that wicked context of care, continuity of care, from hospital to community to primary care to home. What is the context of where you're trying to implement broadly at a systems level, and then your individual context in the peninsula, which has its own population, its own dynamics. So context is really important when you're gathering that evidence from practice, and without that understanding, you won't be able to do much. And your learnings from your context adaptation are actually really important to share, because that's the how, and most people forget the how, not so much the what. And then the last part is actually putting all of that into practice with implementation, which is what you've got beautiful examples of here, which bring evidence of improvement. So it's stakeholder evidence, research evidence, practice evidence, which includes context, and then implementation evidence. And then you go around again. So I think the stakeholders and the context are really important.
Absolutely. So context at every point in the research and implementation cycles. People get very intimidated by frameworks, and God knows there's a lot of them. There's hundreds of frameworks, but very much, we work from the position that frameworks are there to serve you, the implementer, and that you can use a hybrid of framework. You can use bits and pick the eyes out of frameworks and mix and match as you like for different parts of the work that you're doing. So can we just hear from three of you how you use the frameworks, and which ones you found useful, and in what parts of the implementation work you used which frameworks? Esther, can we hear from you first?
Yeah. That's an interesting comment that you make, Rhonda, in terms of implementation frameworks making your eyes boggle, because I just did initially think that when I came into this learning, and some of them still make my eyes boggle, and I look at them and think I don't want to look at that. But I found one that worked for me, and I found one that I understood and that worked for the context that I was working within. And I did do a little bit of the picking parts out of different frameworks and using different parts for different aspects of the implementation process. For me, right in the thick of things, when we were right in that storming phase of implementation, I had my implementation models printed out and on the back of my desk and in the back of my diary, so that I could open them when things were really looking a little bit difficult, and just remind myself that this is part of the phase, and what the next steps were, and maybe where I needed to focus my attention on. So using that framework really helped me kind of work my way through in a meaningful and practical way. Yeah,
so it was mostly the CFA you're referring to. Which framework did you use?
I used the knowledge to action framework. And starting to look at the re-aim for the evaluation aspects.
Yeah. And just to fill people in, there are various kind of areas that the frameworks work in. We have what we call the determinants, which give us that context, bigger picture stuff in the beginning, and then we have process frameworks like the one Esther's referred to. So it really is about horses for courses. Diana, what are your thoughts on frameworks? Where are you with that?
Well, my story was a 10-year story before I knew about frameworks for a lot of it, and I was more focused on human factors and design thinking. And through my role that I have at the Design Health CoLab, working with designers to meet unmet clinical need. But I think where it really came in handy, really is vitally important, was the learning health system with the grant application, because when you use a framework like that, which I would sort of describe as like a mothership framework, and then obviously in our grant application we brought in both the COM-B TDF to look at the co-design process, and then the re-aim framework for the evaluation of it. So I think it can get a bit perplexing to begin with, but I think that when you're looking at big national projects that you're trying to bring lots of stakeholders and make an argument for funding, that's where once you use those, the grant application almost falls together because you
and it's a great point, around the flexibility of the frameworks. The frameworks are so flexible in using them in so many ways. So grant writing, also question design. So most of the frameworks have questions against the domain, so you can use them in whatever research endeavors you have. There's the structure comfort that Esther talks about, just that comfort of knowing what the next step are and where you are and being able to keep pegging where you are. Shanal, what's your thoughts around framework use?
Yeah, so when I first looked at the CIFRA framework, I found it quite overwhelming because there's so many sections. But once, I think, you can learn the theory, but you really have to learn on the go as well.
Yeah.
And when I realized that there was a lot of information in the framework, but not all of it was relevant to me, but some of it actually was very relevant. Some of it I perhaps needed to think about, and then others were completely irrelevant. So just dissecting through it and making sure that you've got a systematic way of making sure you've covered all the things that you need to. So CIFRA is overwhelming at first, but once you start working through it, it makes a bit more sense. So that was a journey that I'm still on and still learning. And the new updated CIFRA, I think, has been fantastic as well. So that was a great framework to start off with. I've also am using re-aim, and that was really that was more intuitive because and I think more flexible from a clinical perspective, that I could think about what those each of those components were. And I've used it with PRISM as well to identify the inner and outer contextual factors, which I can then link in with the re-aim framework. So re-aim's been really good. And I'm currently using PIPE metric as well. So I think PIPE's probably the most simple one from a clinician point of view, and that I really liked because it had this quantitative component, because you could identify and say, well, this is, numbers, I guess, felt a little bit more comfortable for me. So PIPE is probably the simplest metric that I've used as well. So yeah, those three frameworks I've used, and you just have to dive in and learn on the go.
Yeah, but what I'm hearing from you,
Can
Shanal,
I give
yeah.
Oh, sorry. I was going to say, can I just give a quick example? So really great to hear you all talk about how you're using the frameworks. One of the things about this, if you think about taking evidence into practice, which is what most of us want to do as clinicians and in change management, or as solving a problem, as indeed many have described here, but even something as simple as getting evidence into practice. I'll give you a quick example. We have developed one of the things we've done is developed a lifestyle coaching program, which is very effective for improved lifestyle change, and have targeted thousands of women in different trials, and it works very well. But it's incredibly effective in pregnancy because there's a lot of prevention opportunities that are not being taken. So we've demonstrated efficacy, which is fine. But nobody could take that intervention and put it into practice because they hadn't thought about these implementation frameworks. And to give you an example, one of the frameworks that Shanal's talking about here about PIPE, we showed efficacy, and then we did a systematic review and showed in 117 trials there was efficacy, and actually advocated for no more research on randomised trials. But not a single one of those studies had addressed the issues that we needed to know how to implement. And the PIPE framework looks at penetration or reach, efficacy, which was, implementability, participation, and efficacy. So the first one, the biggest one, is nobody knew how to reach most of the population. And they've been doing some of this in New South Wales for a long time, and they were getting 2% of pregnant women buying into their program, and they were the most educated, most affluent, least in need. And that's been going for a decade, and they have not worked out how to enhance their reach. And it's because they've never thought about this as it's an implementation problem. How do we implement? So in doing our work around working out what the reach is and how you reach your participants, how you actually implement this and how you get them to retain participation in the program, we've now got it to a point where we can get 97% of women take up the program and 90% of them to stay the whole time, because our focus was not on efficacy, it was on penetration and participation. And you compare that to 2% and a 50% dropout. And they're the same types of programs, but they're just delivered very differently. So if you don't think about these frameworks in the implementation space, a lot of your impact will be far less.
That brings us to an important point, and one I really want to touch on before we finish, which is around equity, health equity, and how frameworks can drive health equity. And you talk about reach and penetration, how the frameworks have helped you do that. Can I just go back to everybody and just talk about how they feel that the frameworks have benefited them in terms of health equity, in what aspects, and how that is how that has been incorporated by using the framework. So Helena, I'll start with you and then work back, just to touch on health equity and implementation and that nexus.
Yeah, really important problem. And one of our team has been doing some fantastic work around the dramatic health inequity around mental health care. So pretty much the more affluent you are in Australia, the less mental health challenges you have and the more access you have to, especially psychiatry care, but also psychology care. And the most equitable care is actually general practice. But if you think about this, if you take that sort of learning health system, or the mothership, as Diana calls it, the first thing you start with was, what is your problem you're trying to solve? And if you think about that, we very much look at how you actually address equity in the problem. So if you start with an equity lens and you realise that actually a little bit of tinkering around the way we currently provide mental health care is useless, we need to completely shake it up, throw it out and start again. If you saw the really stark inequity that is about to be published now. But realistically, equity has to be at every one of those levels. But if you really understand the problem and you bring an equity lens, then you'll be able to get the solution. But if you tag it on at the end and think that consumer involvement and equity is creating a multilingual pamphlet, which is what many people do if they do anything, then you've lost the game to start with.
And as you say, the engagement, giving the voice to the various stakeholders is a really core part of that stakeholder engagement. So Shanal, can I ask you your thoughts around health equity and implementation?
Yeah, so the frameworks really helped, I guess, me connect the dots, and the dots was access to CGM, because it affected the individual level issue of needing glucose data to make those decisions about how to manage your diabetes on an individual level. It affected the service that we provided and the ability to, provide the standard of care that they needed. And so it really highlighted that subsidization for CGM for the group of people that I'm caring for was the biggest barrier. And so that's what I've focused on for the last few months with the advocacy work, with the collaborative submissions. And the interesting thing is that everyone that I've included and have sent lots of emails about this is they all agree. So they've all been talking about it. There's been this shared issue for some time. It's just no one had sort of brought it all together and said, well, we need to address this in this way. And so the frameworks and I guess the consumer-driven advocacy to support this initiative really, was clarified, because it's very streamlined. So it was a very singular issue that we've now decided to tackle.
Fantastic. And Esther, your thoughts?
Health equity was an interesting question for our service, because we do have two different funding programs, and depending on which stream of care our patients were admitted under, they technically had access to different types of services. So our admitted beds have provision of funding for equipment, provision of funding for brokered care like personal care assistance and shopping, whereas our community funded beds don't have that that provided within that funding model. So we had to make some decisions pretty early on within our service development implementation around the equity of service provision and the extra care that people were receiving or could receive under our admitted funded bed. So that was certainly we've certainly had some conversations around that, and we've come to the point where anyone who is admitted under our programs gets treated the same way, is provided with the same things, has access to the same services, regardless of where they sit within those funding models. But it was certainly a conversation that we had to have within the implementation.
Excellent. And Diana?
Yes, thank you, Rhonda. I mean, obviously it's key, and emergency departments, are an area where there's some sort of health equality in that you don't pay to attend most of them, and we have an open door policy. But in terms of frameworks and equity, I think that's where the learning health system comes in, particularly in that area of stakeholder engagement, to make sure that you've got that representation. And then when it comes to your prioritising process, you've got to make sure you don't just prioritise the easy wins in terms of the people that already have the high literacy and access and less illness. So emergency departments are, a key area where we can address health inequity.
Fantastic. And I think we're coming to a close, so I'm just going to wind up. I have been reminded by Jo that I do have a cake making presentation using the CFA, the Consolidated Framework. So if anyone thinks that the CFA is complex, I'm happy to send them the presentation and show you that the frameworks are just, how you use them. And actually, they're quite simple concepts. And you can, when they are used at their best, they are quite simple, and they are tools, as Helena said, for you to use to optimize the work that you're doing. So I'm happy to send that out to anyone who's interested. So I think I'm going to wind up.
And Rhonda,
here.
can I jump in there?
Yeah.
Can I jump in there just before you go to Angela? I have to say, so Rhonda's the core facilitator on the program. Many of us contribute, but Rhonda has got a PhD in health literacy and is really great at stripping complex back to simple, which makes it so engaging. And just to say, there are multiple levels you can engage. So Monash Partners has this community of practice, and there's a series of events, which is really important, and great sharing and narratives like these, and speakers, and there'll be guest speakers through. There's also some resources online. And then once you get down to the more complex offerings, there's masterclasses, which are the 2-day programs, which are not the coaching program. And then there's also the coaching program, which is collaboration across the Monash Centre and Monash Partners. And there's a number of other opportunities as well. So there are many different ways to engage. There's also an online tool.
Yeah, we're just
which is coming out shortly. Yeah.
We're just about to get that online tool and a short course, and that will be accessible. So if people are interested to know about that, they can contact Jo, and we can get that information out to them. I just want to shout out to the people in here today that are doing the current course, the current mentoring course, and great to see many of you here. And I want to thank everybody so much for being part of this today, and hand back to Angela. And thank you, Angela, again for the opportunity.
Oh, that's a pleasure. Thanks everyone for just a engaging discussion. There's been some really positive feedback in the chat. Thanks to our speakers, Esther, Diana and Shanal. We really appreciate you taking the time and sharing your bits of gold from the work that you've done. Just to let everyone know, we'll circulate a link to the recording, and that will include obviously the slides, and there's a number of requests, Rhonda, for your cake recipe, so we can add that as well. Thanks everyone. Keep an eye out for our next event, and thanks to everybody for joining also.